Hello, everybody. Welcome to our 21st Kolokotrones Symposium. So I want to start by thanking the Kolokotrones family for their support and for making this symposium possible. And as you can tell, we are going to focus today on external controls for causal inference with an emphasis on study design and causal inference methods. And we are going to have presentations followed by a panel discussion. And then for those of you in person, there will be a little reception afterwards. So please join us. And with that, I just have a few words of introduction to our panelists. I'm really excited and honored to be part of this theme that, from my perspective, is really a really hot topic in our field and an area where things are really changing as we speak. So this is a very important discussion that we are going to have here today. And I would like to start by saying, like, why do we use reference groups in science to start with, both in vitro, animal, and in human experiments? And we use them to ensure that every characteristic, whether measured or not, is the same in all the groups except for the intervention of interest that we are evaluating, so that if we find an association, we think it is because the intervention is the cause of that association. And we want those reference groups to have the same risks. For example, the indication in case of human experiments, but we also want them to have the same methods for recruitment, enrollment, and data collection, the same outcome definition and ascertainment, whether we are using regular monitoring or we are adjudicating the outcomes, and the same time of follow-up and time frame for diagnosis. So randomized trials are our gold standard and our preferred approach, because through randomization, they help us ensure that the groups are comparable or exchangeable, but they also have other characteristics like treatment support that will help adherence and improve the outcomes in some sense. Imagine that a psychiatric evaluation has the treatment, pharmacologic treatment, but also have some meetings in person support with patients that would affect the outcome. The randomized trials also have blinding that helps the non-differential adherence and also ensures that we have non-differential surveillance or diagnosis. And they have systematic and complete diagnosis through usually monitoring and repeated tests. But randomized trials are costly. So there is an incentive to have smaller trials, smaller groups within the trials, and shorter time of follow-up to reduce cost. And among other things, that's why we sometimes have observational studies. And lately, we have been using the framework of the target trial emulation to try to design our observational studies, emulating a hypothetical target trial, knowing that some of the components of the randomized trials we cannot emulate, and therefore our target trials will not be possible, including placebo or blinding. And when we do that, when we have the two things, why can the results differ? Will take us through all the aspects of the protocol of the randomized trials and the observational studies. So in the eligibility criteria, the target trial, the real trial, the randomized trial, may have more strict inclusion criteria, sometimes explicit ones, but sometimes also implicit ones, like who participates and who has access. When we get to the treatment strategies, randomized trials often have more strict regimes, and so the treatment support might affect the type of interventions that we see in trials. When we get to the assignment, of course, we won't have randomization, we won't have blinding, so we worry about confounding. But we can also have differences in the follow-up from the time from an event of interest, like discharge from a stroke, all the way to the different time of follow-up that we may have in the randomized trials and the observational studies. When we get to the outcomes, of course, randomized trials tend to have really careful monitoring and testing versus sometimes our observational studies we'll be happy if we have positive predictive values of 75 or 95%. And finally, the type of causal contrast that we have in the randomized trials intent to treat per protocol might or might not translate straight to what we do in our observational studies. So with all that in mind, and we might disagree in some of these points, but we can consider when and why can the risks that we estimate in at least one of the groups differ from between the randomized trial and the observational study. And I would say that most of the times the risk, the measure of frequency, is likely to be different for many reasons. And regarding the effect measures, if there is a null, sharp null effect, nobody never has an effect, I think we can get to the same answer often with some exceptions, like if there is confounding in some direction. But when there is an effect, and the likelihood of us identifying the same amount, the same quantity in one and the other is really difficult. There are many reasons for why we might have, at least in one scale, additive or multiplicative, slightly different results in one or the other. So my point here is that it is not only about randomization, where results might be comparable due to a different distribution of measure or unmeasured characteristics, but despite a great protocol that emulate a target trial, there are multiple reasons for us to find slightly different results in one and the other, and not necessarily biases, and perhaps more for risks than for relative risk, and perhaps more when there is an effect than when there is a null effect. So the question that I had in my mind coming here today and really looking forward to the sessions is that then when we want to do data augmentation, we cannot elevate the quality of our data or the quality of the care in the real world. So in order to make these connections, do we have to lower the protocol in the randomized trials to make them more comparable in order for us to then do hybrid designs? And then is it valid to compare the risk from a hypothetical single arm, not randomized, single arm trial with the expected risk in the population overall? For example, okay, there are males 75 to 85, then the risk of MI is going to be around 2% in the next year. That's my reference, and if I find something above that is bad or below that is good. Can we do things like that? Or craft a reference group in a real-world data database, or do a synthetic control group? Like, when can we do that? And we typically don't like to take risks when comparing risks. That's why we prefer internal and ideally randomized references. So when is it appropriate to deviate from that ideal? Is it when we have very strong effects? And I use this totally made up scale. So if we have really, really strong effects, like 100 times the benefit, then probably we just don't need a study. We don't need controls. If we have very strong effects, maybe not 100, but maybe more than 2-fold increased risk, then maybe we are okay with external control groups. But when we start getting to 1.2, can we use external control groups? And sometimes if we are trying to evaluate 1.05, perhaps nobody with internal or external control groups can really get to the results. So I would like to get today to learn from the speakers and the panelists, like, when can we do this? Is it when we have strong effects? Is it when we can predict the risk, when we have harder outcomes? Or can we do it in oncology or cardiovascular, but maybe not in psychiatry evaluations? So with that, this is how we are going to organize the session. We have speakers, 4 speakers, then the expert panel, then the closing remarks, and then the receptions that those of you join us in person, we hope you can join.